All right, so people living with HIV with limited treatment options. Now, I think we all appreciate that HIV therapy has become much more successful. Most people are well controlled. Resistance is becoming less and less an issue. But obviously, there is a group of individuals who still need an effective ART with favorable tolerability profile, lack of cross-resistance to other ARV classes, and new approaches which are convenient and support patient adherence. Now, if you look into definitions by guidelines, who is really a heavily treatment experienced individual? That is kind of complicated. So some say you have to have multi-drug resistant, doesn't really say to how many classes or agents. Some say there should be at least 2 classes resistant. Some say there should be at least triple class biological failure. So it's a little bit interchangeable between what guidelines you're looking at. The European Medicines Agency says treatment of adults with multi-drug resistance for who it is otherwise not possible to construct a suppressive antiviral regimen. So for some of the new drugs, it really means you have to be sort of really needing a new target or drug which you're not resistant against. So it's a little different and not the same definition throughout all guidelines. Now, if you ask yourself how many of my clinic individuals really fall into that definition, and various people have undertaken that exercise, including the Swiss court, and then there's a German study looking at that as well. You can see that if you look at the ones who are heavily treatment experienced, that can be maybe up to 10% of your patient population. But then if you look at those who are triple class resistance, you can see that's only 470 of those 2,000 to 3,000 people in Switzerland from the HIV cohort. And then you look at those who have more than 3 triple class, so like 4 or 5 class resistance, only 14, and how many of them are viremic? It gets less and less, and those with no remaining options. So you can see here for the lower study, which was done in Germany, which was an effort where at least 20 different clinics contributed the number of individuals they had with triple class failure, whether they were suppressed or replicating, and then it's broken down to how many had triple class resistance, how many were viremic, and how many were there with no remaining treatment options. And that captures at least like 25% of all German patients. Well, there were only 6 individuals left with no remaining treatment options. So if you multiply that by 4, then you have 24 individuals who really need a new regimen. And I think that's a little bit the issue. These patients are very, very few. And as we've been talking about the advantages of integrase inhibitor therapy this morning, the message was there is a high genetic barrier and a very low risk of resistance development. So it's not like they're being generated again and again and again. It really means that we're losing these kind of individuals. And for us, in our clinic, there were 2. And those are individuals who either come a very long way, so like the hemophiliacs had monotherapy, double nuke, a first PI which didn't have a good bioavailability, failed that, then got efavirenz into already pre-existing mutations, genetic barrier too low to overcome that, and so forth. So they end up with a very complex regimen, usually with an integrase, a boosted PI, and so forth. But many of them, with the introduction of integrase inhibitors, were actually brought back to suppression. So the number of those who have like 4 drug class resistance are X-tropic and really wait for new drugs is very, very limited. And that is a challenge because that also means that the expertise in the clinic is missing because no one sees these patients. And for companies, it also means they're not going to sell anything. So that's another issue. But if you are in that group of highly treatment experienced, well, you do have a higher incidence of death. You have more frequent comorbidities, a poor life quality. There are issues around stigma. Treatment becomes very complex. And as we have been striving to simplify regimens over the last years, those individuals usually have very complex regimens, often BID, several tablets. So it can be quite complicated. So obviously to avoid that is absolutely paramount. But what contributes to a loss of treatment options? Well, it's really a history of viremia during ongoing antiviral therapy, development of drug resistance. It's more frequent in those who start with a high viral load and low CD4 count. It can be related to suboptimal pharmacokinetics, particularly for those who come from protease inhibitors first generation, where you had to take it 3 times a day or even take it with grapefruit juice to induce the liver and have higher levels. Low barrier to resistance obviously contributed. Polypharmacy, things people buy over the counter which interact with the drug, or think of someone who takes rilpivirine and suddenly is put on a PPI and suddenly has not enough drug exposure, prescription errors, suboptimal adherence, poor tolerability, because if you don't tolerate your regimen, how are you going to be able to swallow that every day? Psychosocial challenges, and then financial struggles, which may also lead to interruptions and eventually increases your risk for resistance development. Now, the guidelines have a whole set of information and recommendations to what to do when you do develop virological failure, which is really more about trying to make sure that you don't have one virological failure after another. So in the development of ART, we learned adding monotherapy to monotherapy is not very helpful. So there should be at least another, at best 2 active other drugs, so that you have a 3-drug active regimen in individuals who already have accumulated considerable resistance. And for that, really, I think in 2022, we have a growing armamentarium of drugs available. So actually, there are a lot of options, including monoclonal antibodies. The first one has been licensed in the US, and it was temporarily available in Europe, ibalizumab. Then we have a licensed attachment inhibitor, fostemsavir. We have already the positive EMA approval for lenacapavir, so it's already registered, just hasn't been brought to the pharmacy yet, but will be available very shortly. Islatravir, a drug which has also been investigated in this segment of patients, and then broad neutralizing antibodies. Now that's more down the line, so I'm not going to cover that. I'm just going to cover those which are already available in Europe currently. So ibalizumab is a monoclonal antibody. It binds to the domain 2 of the CD4 receptor. It's a therapeutic class by itself, has no overlapping cross-resistance with other agents. GP120 binds CD4 in the presence of ibalizumab, but then ibalizumab prevents conformational changes to GP120 and thereby changes and hinders the entrance, and that works pretty well. The registrational trial was very small, so that's one caveat. There were very few individuals in that, but what they showed is that if you had at least 1 or better 2 other active agents combined with ibalizumab, which you give after a loading dose in the maintenance phase every 2 weeks as an infusion, that you actually then achieved suppression in this very highly resistant patient population in around 50 to 60%. So that worked pretty well. And ibalizumab was licensed in Germany about 2.5 years ago, and there was huge enthusiasm from the company. But having people come every 2 weeks for an infusion is a big step. And then obviously in COVID, no one wanted to have someone showing up every 2 weeks. And the amount of patients after registration and availability of the drug in Germany remained very low. There were only 3 individuals who ever got ibalizumab. So that tells you that the need for these drugs is not that high. And the price negotiations were very unfavorable. They had a very high price. I think it was around something like 60 or 70,000 euro per year. And in the price negotiations, the agency said you can't demonstrate a clear benefit, so the price has to go down to standard ARV. And they said that is lower than the production costs, so we're going to withdraw from the European market. So basically, ibalizumab is no longer registered and available because it has been withdrawn. It's still available in North America, but I have to say, like for me, we do not miss it in the clinic because we have other options and really are not dependent on ibalizumab at this point. Shortly after ibalizumab entered the market, fostemsavir also became available. This is a prodrug of temsivir. It's a first-in-class attachment inhibitor that binds to the envelope GP120, prevents attachment and entry into host T cells, and was investigated in a study called BRIGHT-3. That's a phase 3 study looking at twice-daily fostemsavir. So you have to dose it twice daily. So that's already an additional burden because it's not simple one-day-only intake. With optimized background in people who were highly treatment experienced and had limited other treatment options. And they had 2 groups. One was the randomized group with 3-to-1 receiving fostemsavir versus placebo. And you know that these trials always have these initial, 1 week or 2 weeks at max, where they just want to see what is the antiviral potency of this agent when you add it to the failing regimen. So you just sort of get an idea of the antiviral potency. And then they had a group which was so farly treatment experienced and resistant that they felt it was not ethically possible to put them into a randomized trial, so they got right into the non-randomized trial. And then that has been carrying out for a very long period to see how are the patients doing in this kind of salvage setting. And you can see, if you look at the background agents in the initial OBT, so after the initial 1 week looking how's the antiviral potency, the therapy was amended or adapted according to resistance test, and the best other active agents were combined. And you can see that in the randomized cohort, that was for the most of them, including dolutegravir. Remember that in the presence of some integrase mutations, twice daily dolutegravir still offers some activity, and you can see there was quite a number of BID administration of dolutegravir that arms. Same holds true for darunavir. Remember, in the presence of certain mutations like 58, for example, you have to give it twice daily. So that is also one thing. And since fostemsavir is twice daily, you could say, well, then you have a twice daily regimen anyway. But there were also individuals who had Maraviroc as a new active agent, so hadn't been treated with a CCR5 inhibitor before and were CCR5 tropic. But you can also see that some of them received the monoclonal antibody in the non-randomized cohort, so they were resistant to everything. So then they got ibalizumab on top. And if you look at the overall outcome for randomized and the non-randomized cohort, the randomized one is in black, the non-randomized is in green. And remember, there was also COVID happening, so a lot of time points were missed, which makes it a little difficult to interpret the results. So they have an observed analysis, which is the dotted lines, and you can see that indeed there are pretty much around 80% which respond. In the observed analysis, if you go to ITT, because some people missed their checkpoints for viral load assessment, then it's lower. But I think overall, a pretty good and persistent response over the whole years of administration. I think reassuring, showing that if you are suppressed under this regimen, it seems to work, although it's a BID regimen, but it really seems that this drug has some retained activity and adds for treatment in this very small segment of patients with a lot of resistance. They then presented more recently results looking at what factors influence the outcome. So you sort of want to know, if you have such a patient, how probable is it that that patient is going to respond? Or are there factors which are more favorable or less favorable? So in this 1 week of functional monotherapy, factors which were associated with a decrease of more than half a log was a high viral load, a higher CD4 count, and a higher drug level. So drug level seems to matter. But there was also the presence of relevant GP160 substitutions was associated with a lower odds. So there seems to be some conformational changes in that area which may have an impact on the overall efficacy. That, I think, is a warning signal because it tells you not everyone is going to equally well respond to that therapy. So I think that's something where we at least have some remaining questions. And if you look at the 24-week virologic outcomes, then a lower baseline viral load was associated with a lower odds of virologic response. Higher drug levels was associated with a higher odds of virologic response. And so there were some factors at least which pointed towards who's going to be more likely to respond or not. The safety finding was consistent over time. There were very few drug-related discontinuations. There was a little bit of nausea and diarrhea and headache, some immune reconstitution syndrome in those who started therapy. But I think in general, the overall rate of safety was good. And for my own patients, I would say that works pretty well in this segment of individuals. Real-world experience is very limited because everyone only has few patients. We have 3 fostemsavir-treated patients in our cohort, so that's just a very low number. This is, again, from this OPERA cohort, which I already showed you for the 2-drug therapies, so these 22 states, 96 clinics from the US, and they had 31 individuals who were suppressed when they got fostemsavir, most likely because of tolerability issues with another component, and then they had 55 who were replicating and received various range of other drugs. Again, you can see that integrase plays a big role, and as well as PIs in that segment of patients. And if you look at this very busy slide, I think the overall message here is that those who were suppressed and switched obviously remained mostly suppressed, but the response rates in this real-world cohort for those who were replicating is not really that impressive. It's only like 47%. So that's relatively low and tells us a little bit that probably how important it is that you make sure that you have some other active components on board. And I couldn't find any information of how many other active drugs were given in combination with fostemsavir. The drug which probably causes the most excitement in the setting of limited treatment options is lenacapavir, so the capsid inhibitor. The capsid inhibitor is interesting from many different perspectives because it is interacting at multiple stages of the replication cycle. So this capsid is used or plays a role in various parts of the replication cycle, and as such allows intervention at all these different targets. So that is interesting because it offers a more broad interaction with the replication process. And it is being explored, obviously, in many different clinical scenarios, including PrEP. But here, and that's what led to the registration and licensing in Europe, is the Capella study. And that was done in highly treatment-experienced individuals, and that's the basis of the label. So for people who can't construct another antiviral therapy because of lack of other active agents, can use this new capsid inhibitor, and that is all on the basis of this trial, which included highly treatment-experienced patients with resistance to more than 2 ARVs for more than 3 of the 4 main ARV classes. And they also had a randomized part and a non-randomized part depending on remaining options. And in the randomized part, you have this 14-day monotherapy. So you're staying on your failing therapy, just add lenacapavir to assess the virological efficacy of the compound. And then afterwards, you are on the maintenance therapy. Now, the important thing is that lenacapavir starts with an oral dosing. So you get 600 milligrams, which are 2 tablets on the first day, the second day, and then day 8, you get 1 tablet, followed by an injection. And the injection is then given every 6 months. Now, I think for anyone who works in HIV, 6 months is an exciting, because that means, yeah, you want to see patients maybe only 2 times a year. This would fit really into your general way how you manage individuals who are living with HIV. So that is obviously some excitement. But obviously, since it's the only drug which is given every 6 months, the question is, what can you give it with? And I think that's probably the bigger question behind the development of lenacapavir. But here, for the individuals who were highly treatment experienced, obviously there was excitement to allow a whole different new mode of action in these individuals. And if you look at the baseline characteristics, it's really kind of impressive to see how much resistance there was. And you can see that there was probably no one who has not developed NRTI resistance, NNRTI resistance, a huge amount of PI and integrase resistance as well. So a lot of people with more than 4 drug class resistance, so really a very difficult to treat patient population. But note again, how many patients are in such a trial? So the total is 72 individuals, because it takes a whole global effort to find these individuals to put them into a trial. So that tells you it's just not the common patient you're seeing. Now, looking at the primary objective, so viral load decline after 14 days is 2 log. That's really a lot for a single agent. So that tells you there's a very big antiviral potency for this compound. And in contrast maybe to the fostemsavir, there is no changes in the envelope which may have an impact on how this drug will perform or not. So it is works pretty much for everyone, and seems to have a higher antiviral potency than some of the other drugs in this segment of patient. Looking at the outcome, you can see that an amazing amount of around 83 to 86% achieve virologic suppress. So that's really quite sensational in this multi-drug class resistant patient population. If you concentrate on the right, you can see that having another fully active agent adds a little bit, but not really that much. But I think there's a word of warning, because if you say 0 active, doesn't say anything about, are you adding 3TC to preserve the 184V? What other drugs become hypersusceptible in the presence of certain mutations? So I think that's very difficult to interpret. There were some individuals who developed capsid resistance, so it doesn't have the high genetic barrier of its 2nd generation integrase. If there was an adherence issue or no fully active agent, some individuals develop resistance. So that's, I think, really underlines why there should be another active agent at least. And the overall most important side effect are probably injection site reactions, but that was relatively mild, and very few patients discontinued because of that. Just to finish off, I think management of people living with HIV with limited treatment options is important that you do that in a team. So sometimes we discuss that in a whole round with the virologists, which drugs can still be expected to have some added value. Obviously, if adherence is the underlying cause, it doesn't make sense to add one regimen after another, but then really think, how can we improve adherence, or is there a way we can get the patient to get into sort of a different drug delivery system by delivering the drugs at home or using a long-acting? Is there a need for taking care of mental health issues in the first place and then maybe restart therapy? So I think there are a lot of things to discuss, and clearly this is something which is probably not only best in the hands of a clinician, but a psychosocial management as well, and obviously with the virologist. So in summary, I think it's exciting for people who have been waiting for these new drugs, because new modes of delivery and new drug classes clearly have led to the advent of new treatment options. I think the bigger question is, what for people who are multiple drug exposed, have resistance and are suppressed, but have some difficult side effects and want to simplify their therapy or improve the tolerability? Could we use some of these agents? I think it will depend a little bit on the price. And so I would say we have really exciting new options for highly treatment experienced patients emerging. And I think that really offers a great promise. Thank you very much.